cholecystitis and acute acalculous cholecystitis. From the name itself, it is understood that one is in a condition where there is calcular obstruction. That is, calculus, the gallstone will be obstructing. Because of that, cholecystitis can occur. And the other one is acute acalculous cholecystitis, which is not associated with the gallstone. And the mode of infection is told like how the infection can spread. It is hematogenous from the cystic artery. It can spread through the portal vein. It can spread, and through bile also the spread can occur. Next is pathogenesis. Pathogenesis of acute cholecystitis. So what happens is that the stone causes obstruction at the Hartmann's pouch, or in the cystic duct also it can occur. So when the stone gets obstructed in the pouch, this obstruction can cause a stasis inside the gallbladder. There can be stasis. Because of that, there can be edema. There can be infection. Because of the stasis, there can be bacterial infection. The spread of infection will be in a increased manner. Because of this, inflammation can occur to the gallbladder. And the impacted stone also causes mucosal erosion. That is, due to the impacted stone, there will be mucosal erosion, so that the bile salts will act over the submucosal tissues. When the mucosal erosion happens, the bile salts will get direct touch to the submucosal tissues, and for these tissues, the bile will be toxic. And as a result, there will be necrosis, further infection, perforation, etc. So this is what is the pathogenesis of acute cholecystitis. What is happening inside the gallbladder in this condition? Why this is happening? So next is pathology of acute cholecystitis. That is, when this acute cholecystitis happens, what is the presentation inside the gallbladder? What happens to the gallbladder? So there will be gallbladder distension, and the gallbladder wall will be edematous friable wall, and the wall contains dilated vessels. There will be areas of necrosis and patchy gangrene. That is, in severe cases, there can be necrosis and gangrene in the gallbladder. In the mucosa, there can be ulceration and necrosis. And inside the lumen, the content will be pus, or infected fluid will be the content inside the lumen. And in the histology also, features of acute inflammation will be seen. That is the pathology of acute cholecystitis. First, we have seen the pathogenesis, how this inflammation is happening due to the obstruction of the stone, how it is leading to the inflammation. Second thing is, when this inflammation happens, how the gallbladder is affected. That is, what are the changes present in the gallbladder. Next is the complications. Complications means acute cholecystitis can lead to perforation, peritonitis, pericholecystic abscess, cholangitis, septicemia, empyema bladder, empyema gallbladder. Empyema gallbladder means same thing, the content, the pus will be filled inside the gallbladder. Then gangrenous gallbladder. The infection can lead to gangrene or necrosis. All those things can occur. And these are the complications, main complications of acute cholecystitis. Next is the clinical features, how it is presented. There will be sudden onset of pain, and the pain will be, according to the location of gallbladder, the pain will be present, that is in the right hypochondrium, and there will be tenderness, guarding, rigidity, etc. And on palpation, there will be palpable, tender, smooth, soft gallbladder. Gallbladder will be palpable, and there will be area of hyperesthesia. Hyperesthesia means severe, means the sensitivity will be increased. There will be hyperesthesia, that area between 9th and 11th ribs. That is the posterior side and the right side, the 9th and 11th ribs, between that area, there will be hyperesthesia. And that sign is called the Boyas sign. In addition to that, jaundice, fever, nausea, tachycardia, etc. will be present. And another thing is Murphy sign. It is also called as mid-inspiratory arrest. That is detailed in the coming slides. These signs will be positive. So clinical features of acute cholecystitis. First thing is pain. That is, it is an acute condition. So the pain will be sudden. So sudden onset of pain in the right hypochondrium. There will be associated with the pain, there will be tenderness, guarding and rigidity present. On palpation, there will be tender, smooth, palpable gallbladder. And two signs which is told in this acute cholecystitis condition is Boyas sign and Murphy sign. Boyas sign is an area of hyperesthesia between 9th and 11th ribs posteriorly on the right side. And Murphy sign, it is a mid-inspiratory arrest. Then in addition to that, jaundice, fever, nausea, then tachycardia, etc. also is seen in acute cholecystitis condition. Next is the treatment. And before treatment, the investigations which will be suggested in this condition are ultrasound abdomen. That is, it will be very useful and it will reveal the presence or absence of gallstones, the thickening of gallbladder wall. All these will be evident in the ultrasound abdomen. Then plain X-ray abdomen, that also can be done. And as it is an inflammation condition, total count, it can show neutrophilia. Because of that infection, there can be variation in the total count also. Then LFT, plain X-ray abdomen, CT scan, etc. also can be suggested in this condition. And about the treatment, first thing is hospitalization. Advised hospitalization. And once the patient is admitted, initially we will do the conservative treatment, that is nasogastric aspiration, IV fluids, analgesics and antispasmodics to relieve the pain. Then broad spectrum antibiotics. Because of the infective condition, that inflammation, we will start with the broad spectrum antibiotics. Then proper observation, all these things will be done. And later, according to the need, we will go for surgery. That is, it can be elective cholecystectomy. Once the condition is observed, then we can do the cholecystectomy. In some cases, it should be done immediately. Like in case of empyema gallbladder, that is, pus is filled inside the gallbladder, that condition. Then if there is persisting symptoms, even after this treatment is started, even after the treatments, there is no reduction in the symptoms, or if there is progress in the symptoms, then we have to first go for cholecystostomy. Then after that we will elective, means after a period of time we will go for cholecystectomy also. After 3 weeks or something, we will do cholecystectomy. Cholecystostomy is a procedure where there a stoma is kept to drain the gallbladder. A stoma is kept, and through that the fluid, as we have told the condition, there will be the content inside the lumen, there will be pus or infected fluid will be present. So because of that presence of those contents, there will be symptoms produced. So in order to relieve that, we will go for cholecystostomy, which is a procedure where a stoma is kept to drain the gallbladder. And after that, we will go for cholecystectomy, that is the removal. Okay, that is the treatment for acute cholecystitis.
Excuse me, doctor.
Yes.
Pooja.
Yeah.
Yeah, can you try your phone into landscape mode? Okay, turn your phone into landscape.
Now it
So
is okay.
uh, uh, yeah, now it's okay. Now it's okay. Yeah, you can continue.
Okay. So that is about the treatment. Next it is, so till now we have discussed about acute calculus cholecystitis. from the beginning we are telling when a stone is getting impacted and when the stone is causing an obstruction, then cholecystitis will develop, and those things we have discussed till now. Next, it is about the acute acalculous cholecystitis, where there is no obstruction and due to gallstone. So it is not an uncommon entity, but uh, compared to that calculus variety, it is rare. And it is common in patients who have undergone major surgeries, trauma, burns, etc. And it is common in ICU patients where there is critically ill patients, maybe due to bile stasis, ischemia. Because of the comorbidities, this can occur. Exact cause is not known, but there will be gallbladder distension, there will be these kinds of stasis and ischemia more in case of these critically ill patients. Maybe because of that, exact cause is not known, but still, maybe because of these causes, this calculus cholecystitis develop in these kind of patients. And the pathology is that edema and necrosis of the gallbladder with acute inflammation features. Same thing is occurring, but there will not be gallstone impaction. And the presentation is also acute only, and there can be gangrene, perforation, empyema, etc., which is told earlier. Those features will be present here also. Investigations, isotope study is told, and like uh, earlier I have told, USG abdomen, that also can help. And the treatment suggested is cholecystectomy only, and along with that, open, or the choice is laparoscopic or open, that depends on the condition. So that is about the acute acalculous cholecystitis condition. Treatment is almost same as that only. Next is the chronic cholecystitis. Chronic cholecystitis means that is a chronically inflamed thickened gallbladder which is non-functioning and non-distending. That is, it is not a sudden onset condition, chronic condition only, in which the gallbladder remain inflamed and thickened, and the gallbladder will be non-functioning and non-distending. And the causes told are gallstones, cholecystosis, that is cholesterol accumulation will be there. Then chronic acalculous cholecystitis also can be a cause. And the organisms told are Klebsiella, Streptococci, Salmonella, etc. And the pathology is that here the gallbladder is shrunken, contracted, functioning and fibrotic, and the wall will be thick. Here what happens is that a particular term is told like Rokitansky-Ashhoff's sinuses. That is, the mucosal layer proliferates into the lumen and there will be deep clefts produced in the wall, which is projecting into the muscular wall of the gallbladder. That is called as Rokitansky-Ashhoff's sinuses. So, in case of chronic cholecystitis, because of in the pathology, the mucosa proliferates into the lumen and it will be creating deep clefts in the muscular wall of the gallbladder. That is, sinuses are formed inside the muscular wall. That is the condition. And the muscular wall is atrophied and it is replaced by fibrous tissue. And histologically, there will be chronic inflammation which is visible. That is chronic cholecystitis. And the clinical features are same as that, almost same as that acute only. There will be pain in the right hypochondrium. Then here it is told about the Murphy sign, which was told earlier. That is, in sitting position, we have to ask the patient to get deep inspiration, and then we have to palpate the right hypochondrium. So when this palpation is done, the gallbladder will be brought downward, and if it is in an inflamed condition, it causes pain. So at that point, the patient winces because of pain during the inspiration. When the inflamed gallbladder comes in touch with the palpating fingers, what happens? There will be pain. So that is means when that pain is experienced, that test is told as positive. That is the Murphy sign. So in case of cholecystitis, the Murphy sign will be positive. So Murphy sign is done in the sitting position, and when the same sign is elicited in the lying down position, it is called Moynihan sign. So this is the important one. Murphy sign can be asked for 3 marks like that. Alone also it can be asked. In practice also it is very important. Murphy sign, also called as Moynihan sign. Murphy sign, when the same is done in sitting position, it is Murphy sign, and when lying down position, it is Moynihan sign. As we have told, acute and chronic both conditions, this Murphy sign will be positive. In addition to that, flatulent dyspepsia, that is discomfort in the abdomen, then intolerance to fatty meals, biliary dyspepsia, all these will be present in this condition. Main thing is the Murphy sign. Once again, Murphy sign is the examination point, that is patient is asked to sit, then is asked to take deep inspiration, and we have to palpate in the right hypochondrium, and on palpation the patient winces with pain, that is due to the contact of the inflamed gallbladder with the palpating fingers, there will be pain produced, and the other name is Moynihan sign when it is done in the lying position. Then it is told about the treatment. Treatment is cholecystectomy, removal of gallbladder, that can be laparoscopic or open method. Investigations also same as before: ultrasound, isotope study, LFT, total count, all these can be done as investigations. Next is choledocholithiasis. That is, choledocholithiasis means it is the stones in the common bile duct and the biliary tree. In addition to the gallstones, there can be stones present in the CBD, common bile duct, and the biliary tree, and that condition is called choledocholithiasis. So choledocholithiasis, that stones, there is two types of classification. First is the primary stones, and second is the secondary stones. Primary stones are brown pigment stones, and secondary are black pigment stones or cholesterol stones. So primary stones are formed in the common bile duct and biliary tree itself. That is, the formation itself takes place inside the common bile duct and biliary tree. Whereas secondary biliary stones means, from the name what you get an idea about primary and secondary stones. Primary, I have told, it is formed in the CBD and biliary tree itself. So what can be secondary biliary stones? Annapurna. Primary is which is formed inside the CBD. Then secondary means, how primary and secondary is defined? In any diseases, many diseases you have seen primary and secondary classification. So here what can be the secondary bile stones? No answer. Okay. So secondary means, primary if it is formed in it's inside the CBD or biliary tree. Secondary means they are formed the gallbladder. That is, the gallstones pass through the cystic duct to the common bile duct. That is what is happening in the secondary biliary stones. That is the difference. Primary means it is formed inside the CBD only. Secondary means from the cystic duct, from the gallbladder, the stone is to the cystic duct, and finally it reaches the CBD. That is the difference. And the clinical features are like jaundice can occur. Without jaundice also it can occur. Pain will be there, and fever with chills and rigors also can be present. And complications, liver dysfunction, liver abscess, all these complications can occur. Investigations, as told earlier, US abdomen, CT scan, MRCP, blood, that is total count, then ERCP. All those investigations also can be done. And the treatment, it is told that injection vitamin K can be given, IV antibiotics can be given, and if there is dehydration present, then that can be corrected. Then ERCP acts as therapeutic also. That is, we have to extract the stone through Dormia basket or balloon catheter. Through the different techniques, the stone have to be extracted, and then if needed, we have to go for cholecystectomy also. That is about polydocylithiasis. And next is obstructive jaundice. Obstructive jaundice, first it is told about the causes. So the obstructive jaundice can be caused due to certain tumors in the gallbladder or in the surrounding structures. It can be due to structure present to the CBD, to the common bile duct. There can be stricture present, and due to any polydocus cyst, it can occur. Any type of compressions, if it is, means if there is any obstruction, that is, the jaundice can be developed due to the biliary obstruction. So it can be caused due to any of these pathology. And next is the symptoms, how the patient will be presenting in case of an obstructive jaundice. Obstructive jaundice is also called as surgical jaundice also. And the symptoms are itchiness will be there, abdominal pain will be there, weight loss will be there, vomiting, then fatigue, dark urine. All these features will be present in a jaundice patient. The investigation suggested as serum bilirubin, serum albumin, prothrombin, serum alkaline phosphatase, then ultrasound abdomen can be done, ERCP, all those routine investigations can be done here in this condition also. And the treatment options for obstructive jaundice is depending on the cause and the severity. That is, if it is due to CBD stones, we have to remove the stones, then or else we have to do polydocylithotomy, that is, the grinding of the stones should be done. And if there is a carcinoma condition, then according to that, if there is a carcinoma of pancreas, that is the cause for obstructive jaundice, then according to that, surgery should be selected. If there is stricture present, then according to that, stenting or repair should be done. That is based on the cause and severity, the treatment have to be done in case of obstructive jaundice. And we have told pruritus, itchiness will be present due to the retention of bile salts. So for that, drugs and therapies should be done to manage the pruritus. That is all about obstructive jaundice. Next, different types of tumors are told under the diseases of gallbladder, like gallbladder polyp, papilloma, many tumor conditions are told. Among that, carcinoma gallbladder is important one. So I have taken it and I will be discussing that. Other things will be given in the notes only. So carcinoma gallbladder, it is a common condition and it is common in females and elderly. And the etiology of carcinoma of gallbladder, it is told like it can be due to this gallstones with polycystitis that can develop into carcinoma of gallbladder. Also, there can be choledochal cyst or any types of anomalies in gallbladder like gallbladder polyp. All these can also cause carcinoma of gallbladder. In addition to that, certain infections like chronic typhoid carriers, hepatitis B, hepatitis C. These infection also can lead to carcinoma condition. And then it is told about the genetic variation. It's not. That is carcinoma can be having a genetic involvement also. Next is the symptoms, the features of carcinoma of gallbladder. First is the pain. Pain, as told earlier, pain will be in the right hypochondrium. Then jaundice can be present. As in other carcinomas also, here also there can be significant weight loss. Then acute presentation of cholecystitis. All those features will be present. The pulp means liver, secondaries, any other secondaries have to be checked. That is the symptoms. Then about the staging. About the staging of carcinoma, you know, different criteria are there. Main thing is TNM classification, that is tumor, nodules, and nodes and metastasis classification according to the spread, according to the metastasis and all. We will grade the condition. Based on that, staging will be done, and the prognosis will depend on that. Next is the treatment for gallbladder carcinoma, that is surgery is told, and like other diseases, chemotherapy, radiation therapy, targeted therapy, all those are suggested in gallbladder carcinoma also. Next is the treatment. Cholecystectomy is asked in the question papers also. So we will go in detail about the cholecystectomy treatment. So cholecystectomy is the removal of gallbladder. Cholecystectomy. So how the procedure is done in the pictures, its detailed thing is explained in the notes, but still with the pictures I will explain what is cholecystectomy. As I have told, cholecystectomy is the surgical removal of gallbladder. And while explaining the cholecystectomy, it is told that different methods, different types of approaches have been told. First, about the indications of cholecystectomy in case of gallstones. In today's class itself, we have seen in different diseases, cholecystectomy is indicated, like gallstones, cholecystitis, and its complications like empyema gallbladder, mucosal gallbladder. All these conditions, cholecystectomy is indicated. And its approaches two types: open and laparoscopic. And open is again on the basis of the incision. Again, it is divided into different types. So the technique as such, it is like after opening the abdomen, the colon is pushed downwards and the stomach is pushed medially, so that we have to visualize the gallbladder. And there are two methods mentioned, that is the duct first method and the fundus first method. Two types of techniques are mentioned for open approach cholecystectomy. That is, first one is about the duct first method. That is, here the Calot's triangle is dissected, and we will identify the cystic artery. Then that ligation have to be done. Then cystic duct is ligated. Then the gallbladder is separated from the gallbladder fossa. That is the inferior surface of the liver. From that, the gallbladder is separated and it is removed, and then proper hemostasis is maintained. That is the duct first method. That is, we will go for the cystic duct, identification of cystic duct, and it will be ligated, and then gallbladder will be separated and removed. That is the duct first method. Then it is the fundus first method. That is, in case of difficult bladder due to adhesions and all, if it is difficult to find the cystic duct, then we will go with the fundus first method. Fundus first method means the fundus is separated from the liver bed. Then dissection is properly carried out. Then this cystic duct, cystic artery, all these are identified, and these are ligated. Then proper removal is done. In both the cases, drain should be placed for the proper drainage, and it should be removed after the 72 hours. And in certain cases, in on table cholangiogram, and also they will, then we have to go for the cholangiogram. That is, proper investigation have to be done even after the cholecystectomy procedure. That is the surgical removal of gallbladder cholecystectomy. That is the open method. And here in this picture, just I will explain the picture. it is seen that the incision is made in the Koch's incision is made. Here we can see the incision. Means first it is cleaning and draping is done, then the Koch's incision is put, then through the layers, the erectus muscle till that the cut is made. Then exploration is being done. Then in the third picture, first picture, it is like we are pulling down the liver. Okay. Then there itself, the last one, it is we are exposing the gallbladder. Gallbladder is exposed, means proper retraction of liver is done and the gallbladder is exposed. Then in the next last section, that pictures the gallbladder fundus is picked with the sponge holding forceps. That image is seen in the last series. Okay, first picture is holding the gallbladder fundus with the sponge holding forceps. Then the Hartmann's pouch is retracted down. Then Callet's dissection. Callet's triangle is getting dissected. Then suction dissection is done. Then we are doing the separating the gallbladder from the liver bed. All these pictures are about the retraction and separating the gallbladder from its inferior surface of the liver. Meanwhile, we have to identify the cystic artery, CVD, cystic duct, etc. And according to that, here in the first image, we are identifying the cystic artery and it is being ligated. And then cystic artery have to be divided. Then suture have to be put. The cystic duct is ligated here. Again, ligations. All these pictures are regarding the ligations put in the duct as well as the artery. Then in the next image, here again the transfixation of the cystic duct using vicryl. It is shown here in the first image. Then again ligations are being put. Then after ligations have been put, the cystic duct is cut with blade or scissor. In the middle image, we can see with a scissor, the cystic duct is cut. Then again, the gallbladder is dissected from its liver bed. And then completely, in the last pictures, completely, the gallbladder is dissected from the liver bed. And this is the final image. That is, we have to keep the gallbladder stump inside after proper removal. Then cystic artery, CVD, cystic duct, etc. are properly placed after ligation. Then the Koch's incision is closed. Then in the second row, the middle image, the drain is placed, tube drain. It is placed after closing the incision. Then the last picture is about the contents. As the gallbladder with multiple stones. It is a case of gallstones. And here in the last image, we will see about the final contents which are removed is the gallbladder and the multiple stones. So this is what is about cholecystectomy, the surgical removal of gallbladder. So indications already we have studied. Next is the approach. Two types are there, open and laparoscopic. And in open method only, again another two methods are told, like duct first method and fundus first method. In the duct first method, we have to identify the duct, cystic duct, and it have to be ligated, and then the gallbladder should be removed. In the second technique, that is in the fundus first method, it will be a difficult gallbladder. That is because of the adhesions and all, it will be difficult to identify the cystic duct. So in that case, we will go with the fundus first method. That is, first fundus will be identified, and then after proper dissection, the cystic duct, everything will be identified and ligated, and then it will be, the gallbladder will be removed. This is about the diseases of gallbladder. So in diseases of gallbladder, as I have told, I have stressed on a few diseases only, mainly cholecystitis, acute and chronic, polylithiasis, and then among the tumors also, carcinoma is taken. And since the cholecystectomy procedure is asked in certain question papers, that also is included. In detail, it is given in the notes. Once you are reading that, you will get more idea about the condition. Okay. So can I continue with the diseases of appendix? Please do respond. I have told you have difficulty in audio, you can respond in the chat option also. I move on to the diseases of appendix.
Ma'am, you can continue.
Annapurna is there?
Yes, ma'am.
Okay.
Then
Okay. So now it is about diseases of appendix. And diseases of appendix, as told, appendicitis is the main pathology which is occurring in the appendix region. And before moving on to the disease, just a glance of the anatomy. We know appendix is a worm-like diverticulum. It is a worm-like structure. It is located at the terminal end of cecum. That is the location of appendix, and the size is told like 2 to 20 centimeter in size. The variation can be from 2 to 20 centimeter in its size, and mainly its diameter is told like 3 to 8 mm, and the diameter of lumen is told like 1 to 3 mm. That is size of a matchstick. That is the anatomy of appendix told. And about its blood supply and all, appendicular artery, then venous drainage, appendicular, ileocholic, superior mesenteric and portal vein, then nerve supply T9 to T10, lymphatic drainage, ileocholic nodes. That is about the anatomy. And in case of appendix, another important thing is, even in question papers, this thing alone is asked, that is the different positions of the appendix. That is the appendix, even though I have told that this is the position, there is clockwise, there is certain variations, and it is told like retrocecal, pelvic, pre-ilial and post-ilial, subcecal, paracecal. So these many positions can be identified in different kinds, in different individuals. It can vary the position. So among that, the most common position is retrocecal. That is 65 to 75%. It is told that the appendix may be retrocecal. This is important. Even the diagram, you can draw the diagram also, because it is asked alone. Position of appendix itself is asked separately in question papers. So appendicitis. So appendicitis, from the name itself, it is clear it is an inflammation of the appendix. Vermiform appendix inflammation is the condition of appendicitis. And next it is about the definitions. Different kinds of appendicitis are told. Acute appendicitis, that is sudden appearance, as the word acute. It implies that sudden onset of the signs and symptoms of appendicitis. Another thing is recurrent appendicitis. Recurrent means repeated attacks. Then it is simple appendicitis, that is the duration of symptoms will be less than 48 hours. And in investigations, in imaging techniques, there will not be any abscess or something. So that is a simple appendicitis. When simple is explained, the next one is complicated appendicitis. That is the appendicitis will be complicated with perforation, abscess, like other complications will be associated with this appendicitis. Next is pseudoappendicitis. That is, it is not an appendicitis condition only, but due to the features, it can appear like an appendicitis, acute ileitis, or Crohn's disease. All these diseases related to the intestine can mimic appendicitis in the clinical features. Next is stump appendicitis. Stump appendicitis means after the appendicectomy, that is, after the procedure is done, we will leave the appendicular stump. To that appendicular stump, there will be inflammation and infection. that condition is called stump appendicitis. So these are the definition, means different terms related to appendicitis. So next is about the etiology. Etiology, this appendicitis condition is common in young males, and it is told that fiber-rich diet can prevent appendicitis. And in certain conditions, it is considered as epidemic appendicitis. That is, it is common in May and August month. There is seasonal variation. That is an epidemic appendicitis. The term is given like that because it is common in May and August month. Then the etiology as such, it is told that viral infection, any kind of viral infection can cause the edema and inflammation of the mucosa of the appendix, and this can cause infection by bacteria and finally result in appendicitis. That is the first one, viral infection. Then it is told family history. That is also relevant. If the first degree relatives are having the pathology of appendicitis, that can run in family. Next is obstruction of the lumen. Main thing is this, that is the lumen gets obstructed due to any cause. That is blockage can be due to fecolith, stricture, foreign body or worm infestations. Any of the reasons can causes obstruction to the appendicular lumen. And because of that, there will be inflammation of the appendix. And another reason told is adhesions and kinking. Same thing. That is near the base of the appendix, if there is any kind of adhesions, that also can cause blockage. Then distal colonic obstruction, abuse of purgatives. Then among that, fecolith is the most common cause. That is the etiology of appendicitis. And the organisms, it is told E. coli, enterococci, streptococci, all these can cause appendicitis. The pathology, it is told like in non-obstructive cases, we have told obstruction can be occurring in this appendicitis case. So we have taken it as obstructive cases and non-obstructive cases. In non-obstructive cases, where there is no obstructions, where there is no blockage, what happens? The process of inflammation is slow and gradual, and a mild attack may completely resolve, or mucosal and submucosal edema can occur. Means it will not lead to that much. It can resolve by a mild attack. That is, there will be edema, and by that edema, it can resolve. In some cases, there will be ulceration of the appendix. There can be, after the edema, there will be subsequent ulceration formed inside the appendix. And because of this ulceration, there can be bacterial infection. And because of this bacterial infection, there will be inflammation, and which can lead to further complications like gangrene and perforation. There is no chance of getting obstruction. Without obstruction itself, because of any cause, there will be mucosal and submucosal edema, which will finally lead to ulceration, which can lead to bacterial invasion, and which subsequently leads to the gangrene and perforation. In obstructive cases, what happens is there will be, because of any cause, there will be obstruction at the lumen, and inside what happens, there will be swelling of the, then inside the appendix lumen there will be lymphoid tissue and all, and these will be getting edematous, and inside itself there will be secretions will be there, and because of this obstruction, what happens, there will be accumulation of these secretion of fluids, and as the fluid gets accumulated inside the lumen, there will be rise in the intraluminal pressure, and due to that pressure there will be congestion of the vessels and all, and it can lead to ischemia. And in addition to that, there will be bacterial overgrowth due to the accumulation of the fluid inside. There will be bacterial growth inside, and which this ischemia, this bacterial growth, all these finally leads to the necrosis, perforation, etc. That is the obstructive cases. So two cases are told, obstructive and non-obstructive. This is the pathology, what is happening inside. Same thing only, obstruction, there will be collection of fluid inside, blockage will be there, lymphoid tissues will be affected, bacterial overgrowth will be there. This bacterial spread can cause into the appendicitis, and finally, because of this ischemia and the bacterial growth, it can cause us to other complications like gangrene, perforation, etc. And it is told that after perforation, what happens? This perforated means due to this perforation, there can be formation of appendicular abscess. That is, suppuration and pus inside will be formed, and this is called the appendicular abscess, which is also important, which is separately asked. So next is the clinical features. Clinical features of appendicitis. And the age group is told like it is rare before the age of 2, but it is common in children and other age groups. Before the age of 2, it is considered as a rare condition, but in children other than this age and other age groups, it can be common. And the clinical features told us, first thing is pain. Pain is the earliest symptom, and when we know about the pain, it is like first it will start around the umbilicus. That is a visceral pain. That is due to the initial stage, due to the distension of appendix. What happens? There will be visceral pain that is around the umbilicus. But later the pain eventually becomes severe and it will spread. And because of that, what happens? It will be localized into the right iliac fossa. You know, means appendicitis pain will be, means the exact position is told like right iliac fossa. First it will be a diffuse pain which will be around the umbilicus, that is the visceral pain, and later after few hours there will be somatic pain, and that will be localized to the right iliac fossa. This is due to the irritation of the parietal peritoneum. Due to the inflamed appendix, the peritoneum will be involved. There will be irritation to the peritoneum, and because of that, there will be that localized pain. That is the pinpoint pain at the right iliac fossa. That is about pain. So first pain is around the starts around the umbilicus, and later the pain occurs in the right iliac fossa. Next is vomiting. Then constipation is the usual feature, but in some cases it can be presented as diarrhea also. So constipation is the usual feature, but diarrhea can also occur. Then fever, tachycardia, urinary frequency, maybe because of the inflamed appendix coming in contact with the bladder, it can cause bladder irritation, and that can lead to urinary frequency. Then certain signs are important in case of this appendicitis. The first one is, main thing is the pain. It will be at the McBurney's point, and at that point only in the notes it is clearly given what is McBurney's point and all. So at that point there will be severe tenderness, and the tenderness is of two types. Rebound tenderness is the next one. Normal tenderness will be there. Another one is rebound tenderness. That is, once we are palpating, when we remove our hand, there will be increase in the pain. That is release sign or Blumberg sign. That is, once the tenderness is present at the point, when we palpate deeply and when we suddenly remove our palpating fingers, there will be increase in the aggravation of the pain. That is release sign or Blumberg sign. Another sign is Rovsing signs. Rovsing signs means on pressing the left iliac fossa. You know the pain is in the right iliac fossa. So we will press on the left iliac fossa. So pain is in the right iliac fossa and we will be pressing on the left iliac fossa. But when we press on the left iliac fossa also, pain occurs in the right iliac fossa. That is due to the shift of the bubble loops. From left iliac fossa, the loops get shifted to the right side, and this will irritate the parietal peritoneum. So there will be pain in the right iliac fossa. That is the Rovsing sign. Next is two tests are told. That is the Kopp-Soyas test and Kopp's obturator test. That is hyperextension, when means there will be irritation of the psoas major muscle when we flex the hip, or when the extension of hip along with the and the flexion is done, then there will be irritation to the psoas major muscle and it can cause pain. That is seen in retrocecal appendicitis. Next is Cobb's obturator test that is seen in pelvic appendicitis, that is based on the position of appendix, that appendix occur and different positions. It will not be positive in all kinds of appendicitis. Always you have to note that it will not be positive in all appendicitis. In case of retrocecal appendix, there will be pain in the hyperextension of hip joint, that is the Cobb-Soyas test. And next thing is, in case of pelvic appendicitis, Cobb's obturator test will be positive. That is when we do the internal rotation of the right hip, that will cause pain in the right iliac fossa. Hyperextension, that is in the Cobb-Soyas test, that is retrocecal appendix. And internal rotation, that is in the obturator test, that is in pelvic appendix. That is the next test. Another one is Baldwin's test. That is when legs are lifted off the bed with knee extended, the patient complains of pain while pressing over the flanks. The patient is asked to lie down and then the legs are lifted off the bed with the knee extended and we have to press the flanks. That time pain will be experienced and that test is called Baldwin's test. And rectal examination also shows tenderness in the right side. Then another thing is the hyperesthesia in the Sharon's triangle. Sharon's triangle, this is the Sharon's triangle. Sharon's triangle is formed by anterosuperior iliac spine, umbilicus and pubic symphysis. The triangle formed with these 3 points, this is called the Sharon's triangle, and in that area there will be severe pain, tenderness, hyperesthesia in the Sharon's triangle. This is the clinical features or the main signs or tests which should be done in the appendicitis case. And as I have told, depending on the position, there will be different observations of pain. Then investigations, total WBC count, urine examination, plain X-ray, then contrast CT, ultrasound, all these will be helpful in the diagnosis. And next one is the main criteria, or this criteria is used for the treatment, that is whether we have to go for surgery, whether we have to confirm the condition. For all these things, the main criteria or main scoring system is the Alvarado scoring for appendicitis. So in case to avoid negative appendicectomy, that is if it can be managed by conservative treatment or it should be taken for surgery, that should be determined by this Alvarado scoring system. And according to certain features, the scoring is done. And it is told like migrating pain, anorexia, nausea, tenderness, rebound tenderness, elevated temperature, leukocytosis, shift to left, all these things. Based on all these features, it is told that we can confirm the diagnosis or we can decide whether there is a need of appendicectomy or it can be managed by conservative treatment. So first thing is the migrating right iliac fossa pain. So we have told the pain, it is first it is umbilical region, then the pain moves on to the right iliac fossa. So the pain is told like migrating right iliac fossa pain, whether it is present or not. So if it is present, it is given score 1. Next it is anorexia. There will be taste, loss of taste, loss of appetite, all those features will be there. If it is present, then another score is given 1. If nausea or vomiting, that symptom is present, again 1 is means another 1 score is given. Then according to certain signs, that is first thing is tenderness in the right iliac fossa, the typical position it is told. Then rebound tenderness, and if there is tenderness in the right iliac fossa, the score is 2. Then rebound tenderness means the thing we have told, while we have palpated deep, and suddenly when we remove the palpating hand, there will be aggravation of pain. That is the rebound tenderness. If that sign is present, then it is given 1. Then elevated temperature, that is fever. If elevated temperature is present, then score 1 is given. And laboratory findings like leukocytosis and shift to left. Shift to left means that bands or stabs have increased. That is the progress in infection. That is considered as the shift to left. And if those features are present, then again 2 and 1 score is given, and total a score of 10 is made for this scoring system. And the score, if it is less than 5, we are not sure whether there is the condition is appendicitis, and we should not go for appendicectomy. Then 5 to 6 it is compatible, 6 to 9 it is more, probability is more, and if the score is more than 9, it is confirmed that appendicitis diagnosis is confirmed, and we have to go for surgery. That is the Alvarado scoring system. This is very important, and certain other scoring systems are also mentioned, but still this is the main method, main criteria for the appendicitis condition. And it is, when mnemonics is given like mantras, MANTRELS. You should not left out any of the features, so it have to be remembered with that mnemonics like mantras, MANTRELS, and you have to, means in that order only you have to by heart. And other scoring systems like Kalam modified Alvarado scoring system, where the shift left is removed, and another thing is Anderson scoring system. Certain other scoring systems are also mentioned, but of which this is the important one. And next is the treatment, that is surgery, that is appendicectomy. And the appendicectomy also, based on the incisions, there is different approaches, that is Bredin incision, Rutherford Morrison's muscle cutting incision, Lansky's incision, right lower paramedian incision, laparoscopic approach. So many approaches are there based on the incision and all. We will see about the open appendicectomy or the general appendicectomy ones. Indication as told, acute appendicitis, recurrent appendicitis, appendicitis in pregnancy. All these conditions are indicated for surgery. Contraindication is that if there is appendicular mass present after an attack of appendicitis, if there is appendicular mass present, then we have to put an interval after 6 weeks or something, we have to go for appendicectomy. Directly we should not choose appendicectomy when appendicular mass is present. Similarly, appendicectomy is not done in acute phase of Crohn's disease also. Then about the types, as told, open appendicectomy is there, laparoscopic appendicectomy is there. Similarly, interval appendicectomy, that is after conservative treatment, we will wait, and then only we have to go for appendicectomy. Then elective appendicectomy is there, same thing like interval appendicectomy also, because we will wait for a few period and then only we will go for appendicectomy. Then emergency appendicectomy is also there at time of certain acute appendicitis. Emergency appendicectomy is also advised. Here we will mention about the